Welcome back, everyone. Today we're going to talk about a condition that affects millions of people around the world: peptic ulcer disease. This is one of those topics that every nurse should be confident about because you'll see it often in hospitals, clinics, and even in community health settings. So grab your notes, settle in, and let's dive into this together. But before we begin, check out our extensive nurse test bank to help you pass nursing school and the NCLEX. Link is in the description below. Let's start with the basics. Peptic ulcer disease, often called PUD, refers to sores or breaks that develop in the lining of the stomach, the lower esophagus, or the first part of the small intestine, known as the duodenum. These ulcers form when the protective mucosal layer of the gastrointestinal tract is eroded, allowing stomach acid and digestive enzymes to damage the underlying tissue. The result is inflammation, pain, and sometimes bleeding. Now, why do these ulcers form in the first place? The main culprit is an imbalance between the factors that protect the stomach lining and the factors that attack it. Our stomach is naturally acidic. It has to be because it helps break down food. But under normal conditions, it's protected by a thick layer of mucus and bicarbonate that neutralizes the acid. When something disrupts that balance, ulcers can develop. One of the leading contributing factors is infection with a bacterium called Helicobacter pylori. This little spiral-shaped organism burrows into the stomach lining, producing substances that weaken the protective mucus and inflame the tissue. Over time, that irritation leads to ulcers. Another major cause is prolonged use of non-steroidal anti-inflammatory drugs, or NSAIDs, such as ibuprofen, aspirin, or naproxen. These medications interfere with prostaglandin production, the very substance that helps protect the stomach lining. When prostaglandins decrease, the stomach becomes more vulnerable to acid damage. Lifestyle habits can make things worse. Smoking, alcohol use, stress, and diets high in spicy foods don't directly cause ulcers, but they definitely increase the risk and delay healing. People who have a family history of ulcers are also at higher risk. And let's not forget conditions like Zollinger-Ellison syndrome, where the stomach produces too much acid. Now let's look at how this condition shows up in patients. The manifestations. The most classic symptom is a burning, gnawing pain in the upper abdomen, typically around the epigastric area. Patients often describe it as a dull ache or a hunger-like pain that comes and goes. Interestingly, the timing of the pain can give clues about the ulcer's location. For example, duodenal ulcer pain tends to occur a few hours after eating and might wake patients at night, but it's relieved by food or antacids. In contrast, gastric ulcer pain often occurs shortly after meals and is sometimes worsened by eating. Other symptoms include bloating, belching, nausea, and in some cases vomiting. If the ulcer bleeds, you might see hematemesis, which is vomiting of blood, or melena, which is black, tarry stools. In severe cases, ulcers can perforate, meaning they create a hole through the stomach or intestinal wall, leading to intense pain, rigid abdomen, and signs of peritonitis. When you're assessing a patient, it's important to ask about their medication use, alcohol intake, and stress levels. Many patients won't realize that their pain relievers or their smoking habits are contributing factors. So how do we diagnose peptic ulcer disease? The most definitive way is through endoscopy. An upper GI endoscopy allows the healthcare provider to visualize the lining of the stomach and duodenum directly, identify ulcers, and even take biopsies to test for H. pylori, or rule out malignancy. Non-invasive tests for H. pylori include the urea breath test, stool antigen test, or blood antibody test. Sometimes, an upper GI series using barium swallow might be used, though endoscopy gives a clearer picture. Lab tests might show anemia if bleeding has occurred, and in severe cases, there might be evidence of electrolyte imbalance from vomiting or poor intake. As a nurse, your role in caring for patients with peptic ulcer disease is incredibly important. Nursing actions focus on monitoring for complications, relieving discomfort, and promoting healing. One of the first steps is assessing the patient's pain, when it occurs, what makes it worse, and what provides relief. Pain management might include giving prescribed medications, such as antacids or proton pump inhibitors. You'll also monitor for signs of gastrointestinal bleeding, such as dark stools, vomiting of blood, or drop in blood pressure and heart rate. Keeping an eye on vital signs and hemoglobin levels is crucial. You'll also ensure the patient remains NPO if there's a risk of perforation or bleeding and assist with fluid replacement as ordered. Education about lifestyle changes is honestly one of the biggest parts of nursing care for ulcer patients. You'll teach the patient to avoid irritants like caffeine, alcohol, smoking, and spicy foods. Also, encourage small, frequent meals rather than large, heavy ones, and emphasize the importance of sticking to the medication regimen, especially if antibiotics are prescribed. Speaking of treatment, let's talk about that in a bit more detail. The main goal of treatment is to eliminate H. pylori if it's present, reduce acid production, and protect the mucosal lining. If H. pylori is confirmed, the standard therapy is called triple therapy. It typically includes 2 antibiotics, such as clarithromycin and amoxicillin or metronidazole, along with a proton pump inhibitor like omeprazole. Sometimes quadruple therapy is used, adding bismuth subsalicylate for extra protection. This combination really helps eradicate the bacteria and reduce acid, giving the stomach lining a chance to heal. For patients whose ulcers are related to NSAID use, the first step is to discontinue or switch the medication if possible. In addition, proton pump inhibitors and H2 receptor blockers, like famotidine or ranitidine, are used to reduce acid secretion. Antacids can be given for quick relief, though they don't heal the ulcer. Sucralfate may be prescribed to coat and protect the ulcer site. In cases of complications like bleeding, endoscopic procedures might be necessary to cauterize or inject the bleeding site. Perforations require surgical intervention immediately. Now, let's think about your patient education role again. Teaching patients how to prevent recurrence is one of the most valuable things you can do. Emphasize the importance of completing the full antibiotic course if H. pylori is being treated. Stopping early can lead to resistance and recurrence. Encourage them to take their medications as prescribed, even when they start feeling better. You'll also want to remind them to avoid over-the-counter NSAIDs unless specifically directed by their provider. Acetaminophen can often be a safer alternative for pain relief. Hydration and balanced nutrition are important too. A diet that includes fiber, fruits, vegetables, and adequate protein supports healing. Encourage them to eat slowly and avoid eating right before bedtime. If they smoke, this is the perfect opportunity to provide smoking cessation resources, because smoking not only increases acid production, but also delays healing. Stress management is another vital piece. While stress doesn't directly cause ulcers, it can worsen symptoms and slow healing. Gentle relaxation techniques like deep breathing, guided imagery, or even yoga can help manage flare-ups. As nurses, we're often the ones who see the small changes first. Subtle signs of bleeding, worsening pain, or anxiety in our patients. Being observant and compassionate makes all the difference. Before we finish up, let's picture a clinical scenario. Imagine you're caring for a patient admitted with upper GI bleeding due to a duodenal ulcer. They're pale, their blood pressure is low, and they're anxious. You'd start by ensuring airway and circulation, placing them on oxygen if needed, initiating intravenous fluids, and preparing for possible endoscopy. You'd monitor vital signs frequently, record output, and keep them NPO. You'd also provide reassurance and stay close by, because your calm presence helps reduce their anxiety while the medical team works on stabilization. See how your nursing care becomes the bridge between comfort and clinical recovery? That's the beauty of our role. Now, before we wrap up, let's test your understanding with a few true or false questions. Ready? Let's go. And that brings us to the end of our discussion on peptic ulcer disease. Remember, the key to managing PUD is understanding the delicate balance between stomach acid and mucosal protection, and recognizing how our nursing care helps restore that balance. From monitoring vital signs to teaching patients how to manage their stress and avoid triggers, your role is vital in helping them heal and stay healthy. Thanks for spending this time learning together. Keep reviewing, keep asking questions, and most importantly, keep caring with compassion and curiosity, because that's what great nursing is all about.